It's
चली
gone
गई
now.
सुनील, तुम्हारे यहाँ से ही आ रही थी।
We are live.
Good morning. Welcome to this Sunday morning special webinar on presbyopia. Presbyopia, I believe, is the only morbidity that affects everyone who lives beyond a certain age. There's no other morbidity in any organ or system more than presbyopia. So obviously it is a universal visual challenge which you're not able to conquer. Cataract has been conquered, refractive errors have been conquered, but not presbyopia. There are several options which you're going to discuss today. The session will be chaired by Dr. Partha Biswas, our president, and the medical director of Trinitralia. Co-chairpersons are Dr. Jeevan Tityal, who is the president-elect of AIOS and also heads the Agarwal Eye Hospital in New Delhi. Dr. Mohan Rajan, vice president of AIOS, and he also heads the Rajan Eye Care Center in Chennai. Dr. K.K.R. Mehta, former chairperson, scientific committee of AIOS, and heads the Mehta International Eye Institute, Mumbai. Our moderators are Dr. Rashmi Deshmukh from L.V. Prasad Eye Institute, Hyderabad, and Jitendra Jethani, Baroda Children's Eye Care and Squint Clinic, Vadodara. And to add to them is Manoj Mathur, Honorary Treasurer of AIOS from Swaroop Eye Center and Medivision, Hyderabad. Our panelists today are eminent, starting from Chitra Ramamurthy from Eye Foundation, Coimbatore, Dr. Indamohan Rustagi from Triveni Hospital, Gurugram, Dr. Krishna Prasad Kudlu from Prasad Netralaya, Udupi, Dr. T.P. Lahane from Raghunath Netralaya, Mumbai, Dr. Amrita Sharma, Chairperson, Scientific Committee of AIOS, and from RP Center for Ophthalmic Sciences, AIMS, New Delhi, Nivian Madhivanan from MNI Hospital, Chennai, Pratnya Sen from Chitrakoot, and Vivek Workar from LVK, Bhubaneswar. Our speakers are well accomplished: Dr. Aditya Sethi from Arunodaya Eye Hospital, Gurugram, Dr. Sunny or Sabyasachi Sengupta from Future Vision Eye Care and Research Center, Mumbai, Rohit Saxena from RP Center for Ophthalmic Sciences, AIMS, New Delhi, and Vardhaman Kankadia, the Young and Dynamic Member Scientific Committee from Asian Eye Hospital and Laser Institute, Pune. That's the extensive program that we have lined up today with a lot of interaction and discussion. I request our chairperson and co-chairpersons to make the opening remarks, after which Rashmi and Jitu will take over.
Thank you very much, Santosh, for this opportunity for all of us to understand presbyopia and the current modalities of treatment. And this is something that I think that's the maximum number of our patients whom we deal with are in the presbyopic age. And that falls in the domain of the comprehensive ophthalmologist. And this is something that should be very important. So anybody who is not able to join in the webinar live, I'm sure would be able to take the benefits and the take-home messages later on when it is on the website as well. So presbyopia, of course, we have the whole array, and right from the glasses to the contact lenses. The multifocal contact lenses have become very, very improved in their versions and provide a lot of cosmetic benefit for our presbyopic patients. Of course, we have also the surgical benefits that have come of age, and we have the laser vision technology, which is also giving a lot of comfort for our presbyopic patients who wish to go in for laser vision. Also, the phakic IOLs have their version of the presbyopic phakic IOLs, which also is a modality that we definitely need to consider. And of course, the pharmacological benefits that can be given by certain molecules is something that is gradually being more acceptable because of their non-invasive nature, because of their repeatability, and because of the simplicity of the introduction. So with these few words, I would request you to go ahead and go ahead with the webinar. And I'm sure it's going to be a very successful webinar. Thank you very much, Santosh. Thank you, everybody, for joining in the webinar.
Dr. Tityal sir and Dr. KK sir, can you also say a few words?
Thank you, Santosh. As you know, today's time, everything has to be corrected. It's not that presbyopia was not corrected earlier also. The problem was we could not reach the people because we have a population which is huge. And I understand, glasses have been there. People had to understand glasses could correct their near vision. And if I see, look, population-wise, there are population who just become presbyopic. These are people, they want various options. While other people who already suffered presbyopia for 5 years or so, they already know what are their options and choices. What Dr. Partha Biswas rightly pointed out, the various ways to tackle presbyopia or correct these or make life easy for our people, need to have a good understanding of each of these areas of correction of presbyopia. Let it be spectacle, contact lenses, or surgical options. I think there has to be clarity amongst the physicians first, and the newer medical therapy for a presbyopia. I think first of all we should have a clarity on these. Then I think we can make our patient understand what is the right choice for each individual. I say each because each individual requires a customization of treatment. One person may be suitable for you can say progressive lenses. Other person may not be. You can't force one particular option for everybody. But today's challenge is, not only giving a laser vision correction, challenge is to reach up to an entire population in periphery also who are deprived of these corrections. Some of them, they don't know that they can be corrected for a presbyopia also. The requirement of glasses are huge. Almost, 1.5 to 2 crore glasses to be given to a population every year. This is a dynamic, if you give today, after 2 years, we have to change the glasses. The huge burden on a government or a NGOs or a people who are going to buy that. Today, I think if we succeed on a medical treatment in one group of population, maybe that will be answer for a longer period of larger population also. I think it's a very good webinar for us to understand what is the right choice for each individual or each group, each population in a society. And I'm very, very sure these speakers are going to make things simpler for all of us. Thank you.
Thank you, sir. Dr. K.K. Mehta.
Having spent all my life being presbyopic, or at least half my life being presbyopic, it is now a pleasure to be without reading glasses at all. I mean, one thing is very essential, what Dr. Tithia said. You have to explain to the patient what he is going to gain and what he is going to lose by the various methods which are available. But now that I am on a trifocal lens, I assure you, life is very comfortable and very enjoyable. When they told me about this today's seminar, I said I have to attend it. Thank you very much, Dr. Santosh, back to you.
Thank you. Rashmi and Jitendra, please take over.
So before Rashmi and Jitendra take over, I think the last question that Keki sir has to answer is what presbyopic corrective IOL has he had in his eyes? I think that should be the last question.
Partho, trifocal. Am I right, sir?
Yeah.
We have to qualify the trifocal a little more, but let that be the last question.
No, let that be. That's fine.
Thank you. Thank you. Please carry on.
Okay, thank you so much to the chairs and the co-chairs for the opening remarks on the session. So as we understand that this is a fairly common condition and that is why this webinar is so important. So the first talk by Dr. Aditya Sethi is just going to be on setting the stage, understanding the unmet need in presbyopia, so to just kind of introduce the session as to why even are we looking at the management options. Dr. Sethi.
Hi, everyone. Sorry for not being there in person. First of all, congratulations to Team Endored, to Nikhil, and everybody behind the product Presview. I think it's a great achievement that today we have a product which gives us an alternative of treating presbyopia. Presbyopia is something that we don't talk enough about, and it's great that in 2025 we are talking about presbyopia. My job here is to talk about the understanding the unmet need in presbyopia in today's world. And is this a new dawn with pharmacological therapies, which is now in 2025 happening? I'm Dr. Aditya Sethi. I'm a refractive cataract and pediatric ophthalmologist practicing at Arunodaya Desai Hospital in Gurgaon in Haryana in India. Let's start with talking about Mr. Rao. Mr. Rao is a 48-year-old chartered accountant. Now there are two Mr. Raos in parallel universes. One is in 1985 and one is in 2025. So the options given to the 1985 Mr. Rao are very limited. He's got very static options for correction of presbyopia, which effectively are readers, bifocals, or progressives. Mr. Rao in 2025 wants spectacle freedom. He has active lifestyles, demands 20/20 and 5 vision wherever he goes. He plays golf, he's on screens every day, and he's driving at night. And you can say he's at the peak of his career. And here is where he's informed about drops, LASIK, lenses, and smart solutions by his doctor. So why aren't we doing this for all Mr. Raos in our OPD? I think it's pretty straightforward to say that presbyopia is the unspoken epidemic which is already here. About 1.8 billion people globally are estimated to have presbyopia. This is a study by Holden et al. It's projected to rise further with aging populations and increased life expectancy. More than 50% of presbyopes in question are in lower and middle income countries and lack adequate correction either because of social stigma or lack of availability of these options. Digital presbyopia is something new that we have discovered. It's onset of early presbyopia by 38 years of age because of the requirement for screens. There's a rise in presbyopic management strategies over time, but it's still, the gap is too large. The economic and social impact includes close to $2.25 billion annually impacted directly or indirectly because of presbyopia. The direct causes could be direct affecting the work efficiency, especially in lower and middle income groups, because here a lot of manual and craft work is happening, and impact on caregivers and household productivity indirectly as well. The quality of life is staggeringly, there's a great dip in quality of life. There's increased dependency, there's a psychological and sociological impact, and there's reduced self-esteem. This is what happens. There's an impact on reading, writing, threading needles, using mobile phones, blurred vision, difficulty in navigation. As something as simple and unique as that is, there's a lot of inconvenience with glasses and economic implications, which includes contact lenses and glasses. The epidemiology and rationale, when we're talking about India and global perspective, we know the global burden is rising. By 2030, we're looking at 2.1 billion people who will require our help. And India specifically has a lot of urban-rural access disparity already. And this has to be met because we can't have loss of productivity either in the rural sector or in the urban sector. And there's a big social impact which happens in India with the requirement for glasses, even if it's for near. And that causes a significant drop in quality of life impairment. The impact is more so on digital strain, labor productivity loss, and all of this requires for newer innovative thoughts about treating presbyopia. This is the article we've been quoting and how beautifully it's been documenting every part of the world having a big labor force reduction as well as unemployment rate. The demographics and onset, we know it typically starts around 40 to 45 years. Onset is more so earlier in tropical zones or higher UV exposure zones. Environment and diet has a role. Occupation, of course, those who do a lot of near work require treatments earlier. And diabetes and uncorrected refractive like latent hypermetropia can be comorbidities. This is a graph which talks about how big the unmet need is of presbyopia correction. So today is the digital age. It's already here. And there's a lot of near vision and intermediate vision demand already exploding into the market. There's requirements for smartphones, tablets, e-books, all of them. And the biggest drawback with glasses is the fact that there's constant dynamic vision requirements between near, far, and intermediate. And judging all of that with glasses and traditional monovision therapies may not be successful. So presbyopia is no longer a personal inconvenience. It's a global public health and economical burden. So this is, I think, very important. The patient's voice. What do they really want? This is something we need to be doing more of, listening to our patients. First and foremost, the freedom from constant dependence of spectacles is something all patients look forward to. There have been 2 surveys which have been quoted here from the AIO and ASCRS, which talk about 70 to 80% patients actually reporting frustration at the requirement for near glasses. Patients want non-invasive solutions. They often hesitate when you tell them a surgical procedure is required because obviously there's a fear to surgery, there's a cost issue, and there's irreversibility with surgery which makes them hesitant. Cosmetically appealing solutions always appeal to everybody. There's reluctance in use of bifocals or readers because of this particular reason, where self-image is sensitive. It's at peak when you're at 40, 45. They want to preserve distance vision to the best of their capabilities. Reason being is because distance vision is something that nobody wants to compromise with. Fair enough. They want to adapt to dynamic visual needs like we spoke about. They want to frequently switch between distance, intermediate and near without difficulty or without the extra effort of removing and adding glasses. So this is what we need to look forward to. 90% are frustrated or irritated with presbyopia. I think it's fairly common and clear that we need to address. Modern lifestyle expectations, they need on-the-go solutions, no extra devices, no surgery, flexibility and reversibility, that they should be able to reverse it if they are dissatisfied. What does 2020 N5 mean? 2020 basically means sharp distance visual acuity so that they can do their driving, they can do their screens, and they can do their daily functioning without problems. N5 is equal to J1 in your chart. It basically means that they should be able to look at smartphones and reading material with precision. The challenge here is that we need to do all of this without compromising contrast, stereo acuity, or inducing dysphotopsias. I think that is where the crux of innovation lies. Beyond numbers, it's all about functional vision without glasses at all distances, and digitally native people and multitaskers are available and they're all over the place. So they need good demands at all lightings and all the working distances. That's the dream. So dynamic vision target and customization is key. We know that presbyopia is no longer one size fits all solution. We need to give our patients a good adequate amount of chair time so that we can profile the patient, set standards for their expectations, and thereafter plan our way to finding the right recipe. There are various factors that we need to listen to when we or look out for when we are finding the right recipe for that particular patient. It includes pupil size, occupational needs, ocular surface and tear film, angle carpine corneal topography, and also talk about neuroadaptation or cognitive adaptability. The mechanism is pretty simple. We sort of decided that it's generally a lens only issue, which turns out it's not. It's a multi-modality. There is lens stiffening, there's ciliary muscle and zonular weakness, there's pupil rigidity, there's loss of neuroplasticity, there is scleral rigidity. That's why there is no one solution. It's a combination of biomechanical, optical, and neural deficits. Hence, our solutions should also be multimodal and also should be individualized or customized. The current solutions or traditional solutions we have leaves a lot of gaps. Let's talk about each and every one of them. First is spectacles. It's clearly widely accessible and cost effective, but the cons include dependence on an external device, inconvenience for a lot of people who are not used to wearing glasses, cosmetic concerns for a lot of young presbyopes who have now been told, okay, you need to wear glasses. They're often forgotten or misplaced because they're not used to wearing glasses, they just leave it and they forget about it. It doesn't address the dynamic visual status that is from near to far to intermediate, which often leads to switching of glasses, which can be cumbersome. Contact lenses, on the other hand, is great cosmetic advantage. It's good for active individuals, but they have to be equally motivated. But the cons include dry eyes, intolerance, chance of infection. Learning curve coming with contact lenses, especially with multifocal contact lenses, can be quite steep. Monovision, when done, it's not ideal for all sort of professionals, especially if you're looking for three-dimensional or accurate vision. And there is a larger cost with contact lenses and maintenance, which is twofold. And of course, there's a lifestyle mismatch which happens with the current traditional solutions and the dynamic young presbyopia. So all solutions that we are giving right now are all static, and the patient needs something that he can adapt with and live their life on the go. These are a plethora of options available for presbyopia treatment today. We have pharmacological therapies which works on the pupil. We have corneal-based procedures. We have intraocular-based options, including phakic IOS with presbyopic correction. We have scleral techniques, including microphorations or implants. We have emerging technologies coming in, which includes gene therapy, mojo vision, and accommodative IOLs. So it's no longer managed by a single tool, but requires a full toolbox. And often you have to do a hybrid sort of a treatment profile. Let's talk about the presbyopic pupil. This is our therapeutic target. Why the pupil? We know by creating meiosis, we constrict the pupil, give a pinhole effect, increase the depth of focus, and thereby give the ability to read. It mimics natural accommodation by improving near vision without affecting the lens position. And it's, of course, it's external, so we're not tampering with the natural anatomy, whether it's the lens or the cornea. In simple terms, it's sometimes small changes like a smaller pupil make a big difference. Why pharmacological therapy? It's non-invasive, it's reversible, it's an on-demand convenience, it preserves distance vision, sometimes even enhances it, and it's customizable and can be combined with other optical aids. What makes pharmacological drops a game changer? Topical solutions offer functional near vision enhancement, fills gap for patients who are not ready for any surgical intervention or glasses or intolerant of contacts. It extends options for early presbyopes who aren't keen on constant spectacle wear. Real-world study shows high satisfaction in appropriate candidates when used correctly. This is a photo from a 2024 launch of PressView, and now finally it's launched again in a bigger way. So we know Pilocarpine has been in the market since 2021 in the US in the name of beauty, and it induces meiosis, increases depth of focus by pinhole effect, and we'll be talking more about it in the coming presentations as we go. Bremicol is another thing which is multicentric trials have been happening in US and Europe and giving such promising results as well. But the limitations to any sort of drop is that it's a temporary solution. It requires multiple daily dosing, may cause dimming of vision, headaches or broache, definitely require frequent retinal checks. It's not suitable for advanced presbyopes or with a higher number or patients with a chronic dry eye, and dim light activities may be affected in some of the users. But for the first time, we can offer something beyond traditional to them without enhancing or touching the eyes anatomy. So what does the real world data say? I'll leave it to my next speaker to talk about the data. So I'll skip this. This is something that I want to talk about is what we need going forward. We need longer lasting formulations. We need less of side effects. We need head-to-head trials, and we need to integrate customization to another level, that is get AI, telehealth integration, part of it, and we need definitely more information about who's the ideal candidate. So every solution comes with a lesson and an invitation to innovate further. So that's something I want everybody to take home. The idea is to get a holistic approach. It's a new tool, and it's not a standalone solution, but integrate it in your plan in such a way that you get the best result for your patient and not just blindly follow the traditional ways of doing things. There's a lot of things happening in the future. Presbyopia has become a topic of interest for many people and many researchers, and a market which is untapped for many companies. So I think it's just going to get better, and we have to have patient-centric care and newer tech and next-gen pharmacological agents involved as well. In conclusion, presbyopia is more than just near vision loss. It's a lifestyle change, and current solutions have gaps, and we need to fill those gaps with more innovative ways of taking care of our patients. Pharmacological therapy is a promising addition, and the future is very bright. So kudos to everybody working towards presbyopia management, and kudos to all the pharmacological teams behind it. Presbyopia management is evolving. Pharmacological drops are a step towards true spectacle freedom. Thank you.
Thank you, Dr. Sethi, for a wonderful talk on just introducing the topic very well there. Any comments from the panelists?
So I would just say that there are two ways of it. One, that we all are looking towards solution for presbyopia, and two, that now that we have solutions, we are also, going retrospectively and trying to treat presbyopia with, drugs which were there for so many years, but the potential is being determined now. So anyway, I think that is a problem. Presbyopia is a problem, as Aditya very nicely highlighted. And although we may have no permanent solution, but temporary solutions can always be there.
So I think the stage has been set to know about presbyopia, what is the unmet need. But whenever, whether it is older drops for which some of the data is available, whenever you are trying it out again, I think we should look into the real world data and the clinical trials. And for that, I think we have one of the wonderful guys in clinical research, that is Dr. Sen Gupta. So I would now like to invite Dr. Sen Gupta to share his presentation on clinical trials for the new Indian pilocarpine drops. Yes, sir.
Dr. Gupta, can you please unmute yourself? You're muted.
Voice is not there.
Yeah. Some of the disclosures. Let's quickly take a look at. You're able to hear me, right?
Yes, doctor.
Yes.
Okay, so I thought, after Aditya's, wonderful presentation, I thought we'll quickly look at a depiction of actually what is happening in presbyopia and what pupil management actually is doing. So it's an interplay between pupil and ciliary body, as well as the elasticity of the lens, especially the lens capsules, which is, all of this is sort of getting affected with aging. And so
the engine of accommodation is the contraction of the ciliary body mediated by the distribution of forces via all elements of the zonular apparatus. The resultant changes in refraction are due to the increased thickness of the lens and the increased curvature of the anterior and posterior capsule. The complex anatomy of the vitreous zonule results in traction on the vitreous membrane peripherally and traction on Weigert's ligament connecting the posterior capsule and vitreous membrane. During accommodation, the ciliary...
So I'm going to try and play it once again. So this is when ciliary body contraction is happening, and there is meiosis, but there is some traction on the, and then when the effect of the drug is gone, the meiosis is gone, the anterior zonules contract and the posterior zonules relax. And if I play it once more, so when there's ciliary contraction, the posterior zonules are actually contracting and causing a bit of traction on the vitreous base. And so this is a little bit of a concern, but then we don't see much clinically happening. But all of this is actually causing the lens to change in its curvature, and therefore for us to enabling us to see. So it's not just the pupil and the meiosis, but also predominantly the ciliary body, which is involved in accommodation. So how it works, how pilocarpine works is it leads to pupillary constriction and also ciliary body contraction. And therefore there is tautening of posterior zonules and relaxation of anterior zonules, like we have seen. Overall, there is a bit of swelling in the lens, increase in the anteroposterior diameter of the lens. So a quick recap, and this is pretty much what we are going to try and exploit when we treat patients with pilocarpine. So pilocarpine and its effects on accommodation have been seen as far back as 2002. So there's a lot of course, data on pilocarpine use in management of glaucoma, or especially angle closure glaucoma, which it still continues to be used there, but that was 2%. Here they have looked at different concentrations of pilocarpine, and mainly in the setting of AD pupils. And we know that we could do that, and then all residents hopefully are learning that as well. But what these authors actually found is that it is also definitely causing increased near vision. And so overall they have used drops as far as 0.03%, and that was also causing a little bit of shift towards reading near vision. Right. So overall, this is a rigid pupil, and there is poor reaction. And these are the these are the people who actually are seeing better, even without any drops. Right. So we all know that and these people don't need any multifocals and all of that. So when somebody already has a very small and rigid pupil, or perhaps a non-dual dilating pupil, pilocarpine may not help much. But this is what we are actually trying to achieve. And in the long run, this is how pupils might become after long-term use of pilocarpine, and we need to sort of watch out for that. So I have been given the mandate of going through the clinical trial specifically with the new drops that have been launched by NTOT, that is PressView. And so before I started, I thought, what we do in almost all clinical trials is convert vision to logMAR units, and that's because fractions cannot be used for for analysis. So this is the N scale, right? So this is N6. N6 is 0.3 logMAR. N8 is 0.4 logMAR. I want all of you watching to sort of remember this. And so when we say 0.5 logMAR, we're talking about N10. When we say N12, it is 0.6 logMAR. So actually getting answers, getting statistics in logMARs may actually, so I've tried to merge all of this, but then overall, just try to remember that N6 is 0.3, not 0. 6 by 6 is 0 logMAR, but N6 is 0.3 logMAR, right? And this is where we want our patients to get. And there have been previous trials, namely the Gemini 1 and 2 trials, the Virgo trial and the near phase 3 randomized trials. And of course, this is the next one in line that was done by NTOT Pharmaceuticals. And so, multicentric clinical trials are not really done in India, right? We don't see much where a lot of studies are recruiting patients from India. We see so many large clinical trials with intravitreal injections and, femtosecond cataract surgery, but very few patients are actually recruited from India. I think this is quite a pivotal point where, now we know that multi-center trials can be done in India, especially in the ophthalmic sphere. We have the patients, patient load, we have the physicians, we have the infrastructure, so we need some good leadership to bring this all together. And, I think this is a great step towards that. So let's start with, this is what was done. So the trial is called Efficacy and Safety of Pilocarpine Hydrochloride versus placebo for the treatment of presbyopia, right? And it has been accepted in IGO very recently, and it's in press. Hopefully it'll be published soon and all of you can see the results. So I'm going to take you through, what was done, what we found, and how it all fits into existing literature. Right, so this is the overall, this is the consort diagram, and this is pretty much overall how it was carried out. The inclusion criteria were men and women from 45 to 55 years of age who were actually complaining of problems in near vision. So they were subjectively reporting problems with near vision. Their best corrected distance vision was 6 by 6. Their distance corrected near vision acuity, where what were used was high contrast charts, was N6 in photopic as well as scotopic conditions. Though, scotopic conditions were not used, they were mesopic, but then for inclusion, they had to be N6 in bright as well as dim light. And then irrespective of distance vision, near vision had to be N6. So if you see, this pretty much is exactly like how our patients look in clinics. Say a 47-year-old lady who doesn't want to wear glasses and is essentially emmetropic for distance, right? So exclusion criteria were distance refraction within plus or minus 2 diopters. Peripheral, and so when you look at the results, almost 90% were actually emmetropic, right? Then of course there are peripheral retinal degenerations for an exclusion, and I've shown you why that might be so, because there is some traction on the zonules and the vitreous base. Of course, prior cataract surgery and IOL takes out the lens from the equation, and therefore just causing ciliary body contraction will not help, but still meiosis might help, and we might still use this in pseudophakic patients, but they were definitely excluded from this trial. And any other intraocular surgical procedures, especially, any corrective surgeries for, corneal astigmatism. And of course, there were systemic exclusions like pregnancy. So, this is pretty much how a patient would look like. So I'm just repeating that, say it's between 45 to 50, 52-year-old gentleman or lady who's actually having difficulties with reading is essentially correctable to 6 by 6 and N6, irrespective of everything else, and doesn't have any retinal degenerations, and essentially is emmetropic. So what was done was patients were screened, and when they met these inclusion criteria, they were actually included into the study, and they were asked to instill pilocarpine, and then they were looked at on the day they started, and then on day 3, day 7, day 14, and then finally on day 30. Right, so this is pretty much what they were told: instill 1 drop every morning. And I've put a video at the back to sort of tell you that this is how our patients might use it. When they're starting their work in their offices, they might actually put a drop, and then perhaps begin their days. So at each visit, what was done was, their near vision was of course checked in mesopic as well as photopic conditions, and this was all very standardized. So mesopic was 10 to 11 lux of the target, and photopic was of course very bright, so that's 251 lux. And then mesopic and photopic high contrast distance corrected intermediate visual acuity was also tested, right? So majority is what we're doing is near vision testing because that's the primary outcome, but also intermediate vision was checked. And this is how the testing was done. So at every visit, patients were looked at as soon as they came in, then at 15 minutes, then 30 minutes, 1 hour, 3 hours, 6 hours, and then 8 hours. On day 1, all these testings were done. So was done on day 14 and day 30. On day 3 and 7, they were not made to sit for 8 hours at a stretch, right? So they were looked at baseline and then at 1 and 3 hours. So what actually happens to them at 8 hours on day 3 and day 7 is something that we don't know from the study. But, it's sort of unfair to keep patients waiting for the whole day on every visit, right? So this is pretty much what was approved by all ethics committees, and this is what was done, and also what was done was, their subjective improvement was also tested, right? So mesopic near vision presbyopia task based questionnaire, or NVPTQ, that's a validated questionnaire that was used, and pretty much all the other previous studies have used this. So it gives you a performance score as well as a satisfaction score, and I'll show you how people behave. Because sometimes the pupil may look small, and they may actually read N8, but then they are not happy, right? So then that's also sometimes very important to look at. And all of this was tested on day 1 and then again at day 30 at hour 3. And the primary outcome actually was this red dot that's at day 30 and hour 3. Right? So what happens, and what was looked at is how many gained 3 lines or more. Right? So that's a pretty stiff outcome measure, right? So, if somebody is N10, 3 lines is like N5. Right? So then, but then, clinical trials should rise up to these kind of outcome measures. So it's good to look at outcome measures which are stringent. So how many actually gain 3 lines? And also, what was looked at was the mesopic distance corrected near vision acuity, right? So mesopic means in dim light, right? So how many people are reading well in dim light? We know that they will read better in bright light. That's because, the pupil will anyway become smaller. But then, therefore, the actual effect of the drug will be seen in mesopic conditions. So therefore, that is therefore also a stringent outcome measure. Right? So it's a very relatively well-designed study with good outcome measures. Right? And then let's look at, how did the drug actually live up to expectations, and, how it performed. So these are a little bit of complex graphs. So let me explain to you what these are. So these are actual near vision acuities, right? So on the y-axis, these are all. So these are at different visits: visit 2, visit 3, visit 4, and I'll come to those. And it varies from 0.6 to 0.2, where 0.5 is N10, 0.4 is N8, and 0.3 is N6. Right? So we want patients to be somewhere around here, right? If you look at baseline, so this is the orange is pilocarpine and the blue is placebo, and these are box and whisker plots. So essentially what we want to look at is this central line. So at baseline, mesopic conditions, people were around 0.5 logmar, that's N10 at baseline. And, so this was, visit 1 was basically the, visit where they were screened. On day 1, as soon as they start using, obviously it was not, it didn't change much. So on day 1 also, if you see on an average, almost all of them were still N10. On day 3, if you see this variability in the pilocarpine group is now reducing, but it is still roughly around N10, maybe a little bit closer to N8. On day 7, this gap is now increasing. If you look at day 14, if you see this has now come to 0.4, that's N8. Right? So the maximum effect has now come on day 14 in mesopic conditions. And then on day 30, if you see, this has gone down even more. So this is quite a big difference between the two groups, where people in placebo are still at N10 and people in mesopic are nearing, pushing N6 or between N6 and N8. So this was in mesopic conditions. This was what the primary outcome was. How do people do in bright light? Because that's where most of our patients are, right? They're not really going to be in very dim lights all the time, unless they're going to a restaurant or something like that, right? So so dim light really is, reading in a restaurant or, and scotopic, that is really dark, is when you're in a movie theater and you still want to look at a brochure or something like that, right? So this is really how they would perform in a restaurant setting where the light is dim. But this is photopic. This is really how they would perform in their routine workplace or, in their offices. So, this is day 1. If you see at baseline, again, they are about 0.5 logmar, that is N10. On day 3, they are still N10. Sorry, they have actually come down a little bit. So they are N8. So on day 3 in photopic light, already they are starting to see a difference. On day 7, they are again at N8. Day 14, they are also again a little bit at an N8, but it has come down a little bit. So they are pushing more towards N6. And on day 30, if you see, this is 0.25, right? So that's really almost N5. So most patients are at N6 on day 30. So what you will see is that there is a progressive improvement. And, by day 3, they will start seeing improvement. So if you just put once and next day you complain to the doctor, oh, I'm not seeing improvement, it's not going to be, right? Because it's going to take a little bit of time. So this is just the pilocarpine group. I've just removed, the effect of the placebo in that. So, this is N10. This is 0.4 is N8, and this is N6 is perhaps even bottom. So this is mesopic. At baseline, most people were a little worse than N8. So about, N11, N12. As soon as they started putting drops, even on day 1, they have improved a little bit. And so this is at half an hour, right? So this is 0.5, that's half an hour. A little bit of improvement. They have nowhere come close to N8, and then they are worsening back. So, but this is on day 1. This is just one drop, right? Now this is visit 3, that is day 3. As you can see, nobody is starting straight away from this. So there is like a cumulative effect. They are actually starting now from slightly better position on day 3, and they are maintaining. There is no drop off like that. And this is day 7. Now you see they are more closer to N8. And, so we, most of the time we would say, okay, you don't put the drop, you're going to go back to 0. But then, on day 7 also, they are actually not starting back from N12, right? They're already at N8 and actually maintaining. On, in the next visit on day 14, they are even better. They're closer to N8. And on day 30, they're actually closer to N6 now, right? That's between N6 and N8, something like that. And then there is continuous improvement. As soon as they put a drop, they will have a little bit of improvement. At 30 minutes, they will see the peak effect, right? So this is the peak effect of the drop on day 30, right? So even if somebody calls us and says, oh, it's been 4 days and I'm not seeing much improvement, that's not how the drug works, because, there is a cumulative effect and things are going to keep getting better and better. And, and then there is a little bit of worsening, there is a little bit of drop off, right? By 1 hour and then 3 hours. But even at 3 hours, if you see, majority people are between N6 and N8. This is mesopic. What about photopic? So I've actually brought it down because this is 0.45 here. And, at baseline, again, the same pattern is seen, and so people are not going back to their baseline visions, right? So most people were N10 or N12, but with sustained use, so this is what most of the clinical trials have not at all evaluated or analyzed, and that data perhaps has gotten, hidden away somewhere. But then, so as we know, the photopic people is slightly better. So people are like one line better in the photopic condition anyway, right? But then how many are, so a lot of them are coming closer to, so 0.30 is N6. I'm repeating that again, right? So maximum effect again is seen at about half an hour to 1 hour on day 30. And then this is also, a little bit maintained overall, right? So there is a cumulative effect. And, when you start from here on day 3, you thought, we would think that this actually would start from here. Again, on day 7, it will start from here, but it's not like that. And, the actual outcome measure, remember that actual outcome measure was how many actually gained 3 lines, right? So how many gained 3 lines is here. So this is 3 line gainers. That's about, this is in mesopic. This is 2 line gainers, and this is 3 line gainers, right? So that's about 31% are gaining 3 lines. This is 3 lines in blue, and additionally another, how many are gaining 2 lines. So this is about 40 to 43%. So when you combine these, you will see that about 60% or more, about 65% are gaining at least 2 lines, right? So like I said, if they are N10, then getting 3 lines is almost impossible, right? Because going to N5 is not possible. But then, so at least 2 line improvement. So if you relax the outcome as a little bit, you'll realize that at least 65% will do well. And this is on day 30, right? And hour 3, right? Similarly, this is at hour 3, and this is hour 6, and this is hour 8. So that, that there is no much drop off on day 30. Well, like we saw some drop offs in the beginning, it's not there. This is the photopic conditions, again, pretty similar, right? So there is a lot of gain in terms of at least 2 line improvement, right? And, photopic, they're already a little bit even better. So getting 3 line improvement in photopic conditions is even harder, but still about 25% have got that. And at 3 hours, which is the primary outcome, that's about 32%, right? So again, at least 65 to 68% have gotten really good improvement on day 30. This is intermediate vision, and I'm not going to go too much into the details because this really wasn't a primary outcome. But again, if you see that at baseline in the pilocarpine group and at day 30, there is a lot of improvement there, and a lot of patients are now 6/9 or let's say N8, and then that is good enough for computer vision, right? So there is good improvement from baseline at 8 hours as well, right? From 0.27 to 0.21. And in the placebo, as you can see, it is not much improvement. So intermediate vision is also improving. What about patient subjective vision or patient subjective feeling? Right? So this is lines of improvement. If you see here, this is satisfaction levels. -1 is like poor satisfaction, 0 is like not much, and then 1, 2 is higher satisfaction levels. So as the near vision improves, right, this is lines gained, right? So 2-line gain, 3-line gain, 4-line gain. There is significant. So this line is almost near vertical. This is as far as it gets when you look at statistics in medicine, right? So as the near vision improves, patients have a high degree of satisfaction, and this is also a total score. So the higher the score, the better they are. Again, the higher the score, the higher the higher the improvement in vision, the better the score. That means people are finding it as good as it could get. What about IOP changes? And this was looked at after a reviewer pointed out that, oh, you're not reporting on IOP, right? So this is how the IOP look like. So it's not really, if you look at the placebo, it's slightly above. So pilocarpine does cause a little drop in intraocular pressure, but the Presview drops at 1.25% with the vehicle that they have is not causing much change in intraocular pressure, right? So as you can see, it really varies not that much from 14 to 15 or so, 15.5, and the mean is about 14.5. So, and across time, it is not changing much. So overall summary is this, multicenter randomized double mask clinical trial with a really good study design. That 1.25% pilocarpine significantly improved near vision acuity, like I told you, in both mesopic and photopic. Photopic is easy to do, but mesopic also, that's really the drug effect. 65% had achieved at least N8, that's at least 2 lines or better by day 30. Treatment showed early improvements by day 3 and good gains by day 7, and sustained effects were observed through once daily dosing and modest improvements in intermediate as well. So the sustained effect or this cumulative effect is really important. How does it rank, amongst other studies? So these are all the studies: Gemini, Virgo, Near, and Pileup, and this is the Presview study. So it's pretty much similar to how they are. So let me quickly show you, how they stack up. So this is how these studies are. The ideal patient is 50-year-old in pretty much all of these, and in the Presview also it's 50-year-old. Here is gentlemen, and here they are more ladies. So a little bit more men in this group. Overall, if you compare how many had 3-line improvements, how many had 2-line improvement, it's almost, you can't tease them apart. So adverse effects were seen in 11% with mild headache in the Presview study, and there was some irritation, some hyperemia, and very few had blurred vision. That's 3%. That's because perhaps there is too much meiosis, and therefore they may have a little bit of blurred vision for distance. So overall it stacked up almost identically to almost all the major clinical trials that have been done before. Right. So you take any metric, so, and, saying just 30% improve is not okay. That's because more than 3-line improvement. It's not 3, it's more than 3-line improvement. It's, that's the ceiling is really high, right? So getting there is difficult. So at least 2-line improvement, 65%. That's, I think, a really relatively large number. So far, it's most efficacious in relatively 50-year-old lady, or I think ladies maybe want this a little more, is what I see in my practice. But this study had more gentlemen in that. Their baseline vision was N10 to N12 at 40 centimeters. Patient is okay with effect lasting for about 6 to 8 hours, like we have seen, and who doesn't mind instilling another drop if they have longer needs. And 2/3, like I said, 65%. So about 2/3, but not all, will gain N6 if you're starting from N10. And about 1/3 will gain N5 also. That's 3-line gain, even in dim light. And there is a cumulative effect of drop seen with max effect on repeated use till day 30, right? So telling that, oh, I'm not getting any use, I'm just, but then you might have put it for just 2 or 3 days. Effect does not go to baseline at all. I think that was also something that most other studies hadn't noted, right? So overall, I think, yeah, overall, large congratulations to Unmet for actually, initiating this study and then, carrying it out across India in multiple centers. And so it does not benefit all. So select well. Repeat installation may be necessary in some. Side effects are rare, and patients to choose along with physicians, and definitely no over the counter, please. Thank you so much. And if you have questions, we can take them now or later.
I think that was a wonderful study. I think a lot of detail, lot of data, and point wise explanation of really good data. But I've just a quick question, and maybe then we can ask everybody else if they have questions. Uh, what do you think is these drugs are going to be used for a pretty longer period of time. So and the bulk of the data or bulk of the studies that have been already published by Gemini or Virgo, and I was going through them, and they are mainly for maybe for fewer months or maybe at the most 6 months. So so should we, I mean, is there any particular data set that these patients would be having a problem and we should be more cautious about that, like cysts or retinal detachment and all those apprehensions that most of us would be having when we will be trying to prescribe it for the first time?
So, I mean, almost all clinical trials have their primary endpoints on day 30.
Yes.
There is not much going forwards. So I think the onus really is really on us to use it and then, come up with a some kind of collaboration where we say that, these many have used it for a year and this is what is happening. So, that is one way of looking at it. The US has something called, data reporting. So there is something from the NIH as well as, many others where, there is a centralized data reporting system where adverse effects are reported by the physician and optometrists. And so there have been some reports of retinal detachment, but then, even in my previous webinar, I had said you need to look at the denominator and not the numerator, right? So if you look at, a population of 100 and you have 5 people with, say, carcinoma, some kind of carcinoma, you'll say, oh, the proportion is 5%. If you have 5 out of 1,000, you'll say like 0.5%. It's fine. But that 5 is still there, isn't it? Similarly, so, when 1,000 people use it and 1 or 2 have been reported with retinal detachment, the percentages are relatively small and relatively, I think it's really minuscule. Also, if you look at some of those retinal detachment case reports, 2 of them were pseudophakic. One of them was a high myope. So then, if you follow these guidelines and, prescribe it predominantly to people who are within -2 and don't have any peripheral degenerations, I don't see much, in terms of complications and retinal complications, me being a retinal surgeon and being more worried about those. What might actually happen is, the prolonged meiosis and then problems related to that in terms of cataract surgery in the future or, driving and all of those. So those are maybe more things that we should look at instead of just catastrophic events.
I actually was more concerned about iris from iris point of view, like the iris cysts and typically known as pilocarpine cysts. Or so I just wanted to know from you, because you have been an active researcher and you must have gone through the previous published data. And that is what I wanted to know. Truly, you're absolutely right that when we talk about complications, we have to go into the denominator as to how many patients actually used. And the best part of pilocarpine eye drops is that it has been it has been a really old pharmacological product, and so there could be data in the background which may already be there because it has been used extensively in last almost 100 years. So just that.
Yeah, so this is most of those are from with 2% pilocarpine, and also remember that the medium used for those higher concentrations was acidic, and these are all neutral. So there is something in the there is a lot of change in the carrier that maybe Antod may want to tell us or not, but the carrier is also different, and 1.25% may not actually cause a lot of iris cysts, and perhaps I wouldn't be.
So that part has been taken care of. That is what was the concern.
Yes.
Wonderful.
Yes.
So if there are any questions, Vivek?
Dr. Sabir, very nicely done study. Dr. Tityal here.
Yeah.
And wonderfully done. Few things I would like to know if you have done those things. Now, your group of patient had a low refractive error, less than two spherical equivalent issues. What happened to this refractive error? Did you compare your results based on the existing refractive error, like a compound myopia, hyperopia? What happened against the rule, with the rule? Was there a difference between these cases with the different refractive errors? Because once you constrict the pupil, the things would change. That was my first query. Second was, what happened to their distance vision? Like there was nothing on our distance vision, because once you use a pilocarpine, there has to be a change in the distance visual acuity also. because you're not only constricting the pupil, you're modifying the, the morphology of lens also. A third thing was, change in the, internal aberrations, higher order aberrations. Because once you constrict the pupil, there has to be change in HOA also. Maybe that is also a very important factor in either improving or a decreasing vision in some of them, I think these three things are very, very important to be discussed in your study. Because I didn't review your case, your paper. Third thing was the peak was 30 minutes after installing the pilocarpine drops. Suppose I am going for a meeting. I have a meeting in the afternoon. Is there a point putting another drop before the meeting, 30 minutes before the meeting? Should we add on the pilocarpine, or you say only it is for a one drop for 24 hours?
So when you look at those graphs, there is, they are looking quite large. The shift is looking quite large, but the y-axis is actually even larger. So, so almost there is no crossing the N8 mark at all. Once you've crossed or gotten better than N8, you will not go below N8 or worse than N8. So it's always between N8 and some may a little bit here and there. So that delta effect is seen large because the y-axis has actually been even larger. So the whole y-axis was from 0.5 to 0.3. So therefore that is looking like that. So that change is not much. The peak and so it's sustained, relatively well sustained. Higher order aberrations were not looked at in this study. I think a lot of centers perhaps did not have it, or it was not in the protocol. So then higher order aberrations were not looked at, but it's, I think, really important. And, maybe, once it's in the market, maybe we should all get together and do something on that. And the distance, unfortunately, what we had in the data set was only best corrected distance vision. So therefore, that data is also somehow, but then I can tell you that almost there were very few more than -1 or like that. So then that spread is also very less. So then, and more than 85-86% are absolutely metro. So then, therefore, most of the times we'll see these kind of effects in terms of strict inclusion.
These patients, suppose they were emetropes. Once we put a pilocarpine, we may have induced myopia. And this myopia per se would have increased their near vision rather than the, the pupillary constriction or a decrease in HOA.
Yeah, so 3% did complain of blurring and 11% actually complained of asthenopia or thereabouts. So then maybe 1 in 10 might actually have that kind of problem as well.
Okay. Yeah.
I just wanted to ask one more thing. What about the fields, visual fields, and also, sir is very fond of it. What about the stereopsis?
So these things were actually not part of that protocol. So, and it was not done.
This is something to complete the picture, like sir said, aberrations, stereopsis, all these things also should be evaluated.
There is data on constriction of visual fields, significant constriction from some previous other studies, and also, difficulty in driving from a large study in an Australian group. Even after 1 month, people are saying, oh, I'm not very happy driving in the night. So then, because there is no mydriasis because of the pilocarpine. So then these are definite issues that we need to, so I think Dr. Rohit might talk to us more about how we can adopt these. I had some slides on that, but then, I'll hear from Dr.
My
Rohit.
query was also similar like Dr. Titya. I just wanted to know if you are having an extended working hours, like all through the day or till late in the night, is there a role for a second drop in the evening?
Yeah, so the study did not ask patients to put that, and strictly not allowed, kind of. So, but then effect is tapering off at about 6 to 8 hours is what we're seeing. So at 8 hours, people may find the need to do that. So, but what it's going to do to the risk factor profile and all the visual fields and all of those is something that we don't know. So it could. So I would, if I'm using it, I'll say try and avoid it as much as possible. Do only once a day, because there is a sustained effect at day 20, day 30 is going to be far better. So not immediately, but then even on day 30, if you see that most people are between N8 and N6, and if they are photopic lights, that is working in bright light, they are N6. Almost all of them are N6. So then at 8 hours also. So even if there is a little bit of drop off, they still be N8 and won't go still to the baseline. So I would not really recommend having a second drop. Most people won't need a second drop, I think.
Yeah. Dr. Sabyasachi, it was surprising, if you compare your study with the, other studies, almost similar results. I had a, thought, because all Indians are, more pigmented iris. And the pupil size is also smaller than the Western people, They're less pigmented and larger people. They should have had a more effect than the Indian population, in terms of getting more constriction. Because whatever study personally I have done, I didn't find the improvement that much, as you rightly pointed out, and 8 was the average in my series also. And in fact, I was very disheartened to see initially, maybe my selection protocol was not very strict, but these patients didn't do well as I thought, But maybe, as you said, if you use for 30 days, maybe the effect will enhance because it's a cumulative effect.
There is a
And my
cumulative.
thought was maybe Indian eyes didn't behave as good as, Western eyes. What is your comment on that?
So that's what. So unfortunately, pupillometry was also not done, or maybe dynamic pupillometry was also not done. So we don't know, who people who didn't improve were, already like 2.2, 2.3 at baseline. So they didn't improve much. So we are not sure. So these are all, I think future study points where, we look at higher order
But
aberrations and
Sabya,
dynamic.
we have done the pupillometry in our cases, measure the pupil size before putting these drops. Then after 1 hour, after 3 hours, after 6 hours, and correlated pupil size with the effect in these cases. And
So,
very soon we'll come out with this result also. We have done all the aberrometry profile also.
right. So ciliary body constriction is also part of the the whole thing. So that is something that we
That
can't
also we
exactly.
have done. We have done the the change in a ciliary body pattern also, and the lens curvature also.
Right.
Hi, Dr. Sabyasachi. Congratulations for your study and a very wonderful talk. So I don't do, the adult practice, but when, this drop came, I was quite excited to understand those patients, particularly children, when we keep them pseudophakic. So I was just trying to look at the literature. There are studies where, these drops has been used in pseudophakics. So the people, there is a group from Iran, if I remember correctly, they have studied 50 patients with use of 1% pilocarpine and use once a day a dose. But it was quite surprising, if you look at their success rate, it was almost 85% improvement in one line and only 4% improvement in 3 lines. So this is something very much, the contradictory when we compare pseudophakic versus, the non-pseudophakic. And the literature, as you said, the long-term efficacy versus, the short-term. So in literature right now, we do have a short-term, the outcomes. And if you look at most of the papers, they have used control as one of the eye. So again, how much we really want to rely in terms of adapting in our day-to-day practice, because those eyes, like one eye is my small pupil, another eye is a normal pupil. So again, we talk about a mesopic effect that creates a lot of difficulty during night vision, especially the driving. That is number one. Number two, also the pilocarpine is known to deteriorate, the Fulfrich phenomenon in patients with, a number of other disorders like, as a neuro-ophthalmologist, I would think about optic neuritis. So apart from that, what I understand in a study with the pseudophakic versus the non-pseudophakic, like normal patients, elderly patient, there is something gap which is we are trying to fail to understand what is the actual mechanism of action of pilocarpine in terms of the ciliary body. Because if we talk about accommodation, that itself is a very dynamic process. It's not the the Donders model where we can conceptualize the pilocarpine works on the ciliary body the way what these trials and they have put forth the mechanism. So what I understand, pilocarpine is probably trying to create the ciliary body spasm rather than you said the anterior and posterior fiber contraction and even the peripheral. That would be the secondary effect. But if we go by this, then this concept of pilocarpine acting at a ciliary body doesn't seems to be the actual mechanism, rather than just pupillary constriction that is giving the effect, and definitely that will help for a near a limited distance, not intermediate and the far distance. That's what I would understand when I went through the literature. Thank you.
Dr. Sengupta, I'm just going to take up a few questions that have come up on YouTube and shared by the support admin here. So Dr. Monica Jitani asks, how many hours does the effect last? I used it myself and the effect goes away after a few hours. So do you want to say something about that?
So then you have used it maybe for a day or two, and I'm 100% sure about it. Unless you
Yeah,
use it for
because
30
your
days,
study shows that the effect is sustaining.
clearly, even on day 3, the effect is not really there. Even at 3 hours on day 3, the effect is not pronounced.
Yeah.
So at least use it for 30 days and then say whether you actually benefited or not. Before that, it's actually a little bit early to say.
Right. Then Naila Kazmi asks, will installation be affecting night driving, and how safe is it to instill the eye drops and drive in low light?
So, I think we are giving too much importance to these things. First and foremost, it was not studied in this trial, right?
Yeah.
And most studies haven't looked at. There is an Australian group where 10% people, talk about problems in driving. That's like 1 in 10. And so, if you really want to avoid it, you can actually ask the patient and, give them a cautionary sort of message that, if you're driving in the night, most people will put it in the day. So by the time they're driving, that effect is actually gone. So I wouldn't really think somebody who's driving a lot is not a good candidate. Perhaps not such a important message. Only thing is, if you have issues, of course, look at it. But just because somebody drives in the night, they are not a good candidate is not the right message to give.
Yeah, understood. She's also asked another question: what is the effect on the patients who have undergone cataract surgery? But I'm not sure if that is something that your trial has looked into.
So no, but then even the previous comment was on pseudophakics. So
Yeah.
The effect of ciliary body on the anterior and posterior lens capsule is totally knocked out here. So effect on pseudophakics is going to be mainly because of the meiosis, and there is no role of ciliary body at all, like in phakics.
Okay. Yeah.
Phakics will respond far better. Pseudophakics will respond, especially those who have baseline large pupils, and so their pupils are anyway larger, and just constricting them slightly may mitigate some of the effects of not seeing too much near vision and all that. So I would be hesitant to comment about too much in pseudophakics. That's because the drug is not meant for pseudophakics.
Yeah.
Right. So there are so many options to correct in pseudophakics, right? So you use a lens, and these are things we discuss with patients even before the surgery, isn't it? How much near vision you want and all that. So therefore, using pilocarpine in pseudophakics is perhaps not at all. We shouldn't even be discussing it, and discussing it in kids is absolutely out of question, because their zonules are stronger, and you might there will be ciliary spasm more in kids in pediatric age groups, and therefore I think peripheral retinal complications will be far more in kids. And and how long do they use it? No, you are exposing them 30-40 years of pilocarpine. That's not at all an option. So talking about pilocarpine for for presbyopia outside the context of emetropic, somebody who's emetropic and just has presbyopia alone is what the actual message would be, and that's almost like 70% of the population, right? So then, I would not really think about all these other things much.
Understood. And Rekha Singh asks, up to what power presbyopia can be corrected?
So most of these were about +2, and they were 50-year-old. The mean age was 50, and they were +2. And most of them were like N12, between N10 and N12 at baseline. So then, that's pretty much how it is, isn't it, in the real world? So, anybody till age 50, 45 to 50, who is +2 and doesn't have any other comorbidities and especially is emetropic, it's a good candidate, I think.
Okay. Sure. Thank you so much. In the interest of time, I think I will skip the other questions and maybe we can take them up later. So we'll move on to the next talk by Dr. Rohit Saxena on real world experience, practical tips and patient selection. So I think some of the questions that we are getting, this talk might answer those questions as well. So over to you, Dr. Saxena.
Good morning, everybody. At the outset, I wish to thank AIOS for giving me the opportunity to be a part of this extremely important symposium and discussion on management of presbyopia. We know that presbyopia is a significantly important problem, particularly in India with its large aging population. Presbyopia per se is expected or believed to affect almost 1.8 billion people globally, therefore making it a major area of public concern. Currently, the only available management are reading glasses, which can be a little difficult to access, especially in areas where spectacle use is limited. The new drug, Pilocarpine 1.25%, which was FDA approved some time back, and now if the Indian Drug Regulatory Authority, the CDSCO, has approved for the use of near vision by increasing depth of focus. They are non-invasive, reversible, and have a rapid onset with minimal reported side effects. I'll just talk about the experience we have gained based on a study that we had planned using Pilocarpine 1.25%, which was prepared by our in-house pharmacy, and I thank our pharmacology team led by Dr. Pandian for that. This was a prospective single-armed trial including 50 patients between 40 to 55 years of age with dark brown iris. The drug was administered once daily for 1 month in both the eyes at 9 a.m. approximately, and the assessment was done at baseline and at 1 month at hour 3, which was 12 noon, and hour 6, which was at 3 p.m. This study has been available as a preprint, and we hope it's going to be published shortly. The important things we actually looked at were, of course, the distance-corrected near visual acuity on logMAR in mesopic light conditions, the near ad power that was required, if at all, the amplitude of accommodation, the depth of focus using the eye tracy, the pupil size, and ocular biometric parameters, which included the axial length, the keratometry, the anterior chamber depth, the vitreous chamber depth, and the lens thickness. We were directly looking at the adverse effects because that was a major area of concern, and we asked the patients to report any adverse events such as headaches, flash of light, etc. We also asked their response to the treatment, especially regarding any challenge experienced in performing routine tasks involving close work or very fine work. This included questions whether they encountered minimal or no difficulty involving these tasks, and how comfortably they were able to carry out these tasks while they were on Pilocarpine 1.25%. The efficacy outcomes were extremely good from our experience, and the distance-corrected near visual acuity improved from 0.74 to 0.36 logMAR. The near ad significantly reduced from 1.4 diopters to 0.4 diopters, and there was a significant increase in the amplitude of accommodation and the depth of focus. The change in the distance-corrected near visual acuity showed a strong positive correlation with change in near ad and the amplitude of accommodation, showing the effect of the drug therapy on both. There was no significant change in distance vision or on ocular biometry, and the patient responses were pretty good to the level of satisfaction, and only about 2.5% actually complained that they could not do routine work probably. However, none of the patients actually dropped in the 1 month study follow-up period that we had examined the patients for. The adverse effects were, of course, mild and did not lead to any discontinuation, and included headache, eye pain, a bit of visual blur, and irritation. Now, based on this experience, I would like to run through some of our experience and understanding about the utility of this drug in clinical practice. So we felt that the ideal candidates for this therapy would be early presbyopes, which would be between 40 to 50 or a little more. Remember, emetropic patients would be more satisfied, particularly non-myopic, because myopic patients often tend to just remove their glasses like many of us do and do our initial period for near work. They need to have a good baseline visual acuity and a healthy ocular surface and brisk pupils. One would definitely not recommend this drug in patients who have advanced cataract or retinal pathology, who have a history of retinal detachment, or have narrow anterior chamber angles. The most important thing is to conduct an intensive counseling for these patients so that they have realistic expectations. One, that the effect is temporary. They may need to use the drug a little more frequently, twice if necessary. The need for daily dosing, the side effects that have been reported, and there may be many more side effects that the patients may start experiencing when this drug is used for long term in a large population, and they may experience mild drop in their distance visual acuity. Again, these are potential problems that can exist or can occur in the patients, but counseling is very important so the patient is aware of what exactly he or she may expect. The important parameters we must look at before initiation is the near and distance visual acuity, pupil size. If the pupil size, and of course its reactivity, if the pupil size is very large and does not change much, that may be a challenge for the use of this drug. And a good slit lamp examination and intraocular pressure evaluation is important. And of course, most importantly, based on the few adverse events related to retinal detachment that have been reported, it's important to do a complete peripheral retinal examination before you start the drug, particularly because once you start the drug and the patient is comfortable and continues to use for long term, there may be a challenge in dilating the patient and examining the periphery. There is some call for avoiding this in diabetics, or at least those patients who have diabetic retinopathy and require to have their retinal examination done frequently to evaluate the stage of retinopathy. So again, there may be no direct contraindication in this group of patients, but may be important because it may impair their assessment of diabetic retinopathy and of course its resultant required management. The other thing that you need to actually consider is the patient's lifestyle and the needs of the patient related to the reading habits, screen time, and occupation. There is a moderate impact of this drug on near, and therefore these habits are very, very necessary to see how much impact this can have. A very transient, occasional near worker may not require these drops at all. However, those persons who are on the desktop or on near devices for long term may require the drug more than once to continue the sustained effect over the entire day. The other important thing, of course, is the ocular health, the ocular surface status, the tearfilm integrity, and the lens clarity. Our experience with pilocarpine has shown that there may be an improvement of 3 or more lines on the uncorrected near visual acuity, and this has been documented in clinical trials. The onset is about 15 to 20 minutes, and the duration is about 6 hours or so. The results are better in bright lighting conditions, which will help the impact or the effect of the drug. There is a variability in the satisfaction that each patient will derive, and therefore it is again important to assess each patient before we start him or her on therapy. And as we have mentioned that the drop effect can decrease significantly after 6 to 7 hours. For a person who is in long hours of new work, consider a second drop after about 6 hours to have a sustained long-term effect. In our experience, 90% patients were satisfied with minimal effect on routine activity, particularly related to near. The best candidates were early presbyopes, emmetropes with a healthy ocular surface. Again, it's important to remember to counsel on the transient effect of the drug, that is, it will last about 5 to 6 hours comfortably, and of course, caution working in dim light where the efficacy of the drug may drop to a certain extent. The adverse effects effectively were mild and self-limiting. Headaches, a little redness of the eye, a little dim vision in low light conditions, transient brow ache. These are essentially reported side effects, not many of them which we saw, but they have been reported in literature. And of course, the long-term safety is under continuous evaluation, particularly in Indian brown iris, where this drug is now recently been introduced, and long-term effects of the drug will come as we gain more experience. We did not have any dropout or serious adverse effects, but again, our study was a short term. And of course, some of the patients have continued to use the drug for continuous use, and we haven't experienced or seen any significant side effects, but a really long usage of the drug and experience on large number of patients is still awaited. No long-term constriction was observed, essentially that after we had stopped the drug for a month, or even some patients who were continuously for a longer period of time, we called them back for dilatation. So there was no sustained effect that prevented dilatation or examination of the retina. So in the 6 or 8 months that we have examined patients who have been on continuously on this drug, these any major adverse events have not been reported or experienced by us. Of course, we know that retinal detachment and posterior vitreous detachment has been reported post the use of pilocarpine 1.25%. And in fact, that was the reason why we had examined some of these patients who were willing to continue for a longer period after 6 or 8 months of continuous therapy. But again, we did not find any significant effects on the retina in the small group of patients we saw who had continued for a longer period. Essentially, to conclude, pilocarpine 1.25% offers a promising non-invasive option for select presbyopes. Of course, the availability of the drug, the accessibility and comfort of the patient is important to see how much sustained use individuals and people can do. But I'm really happy that the Indian pharma industry has moved from just being, a producer, a marketer of pharmacological drugs, to also actually an R&D hub. And we hope that more such drugs, more such promising pharmaceutical therapies are available to the Indian population that can actually, be a lesson or provide treatment for the world. The future direction, which I hope as we gain more experience, would be longer acting formulations, but because again, twice a day or carrying it to the office or to the workplace and using it during your meetings or during your work can be a cumbersome issue. There could also be a role of unims in the dispensing system, that the person can just keep it in the pocket and use it somewhere during half the day has passed, and again an added dose is required. And of course, we need evidence-based twice daily dosing protocols so that people can sustain this effect for the entire duration of the day and be effective throughout the day. So thank you again for the opportunity and the chance to be a part. I apologize that I cannot be in person because of some prior commitment, but I wish you great success with the drug, and I'm sure this is going to make a huge difference to the patients who are going to use this. Thank you.
Wonderful talk by Dr. Saxena there. Any comments, Dr. Namrata, Dr. K.K. Mehta, on the patient selection?
I think patient selection was very clear, and we were a part of the same study that one has to be really careful about the patient selection. This is not a drug to be given to all. Prior refractive error is important. Also, you cannot give it to all presbyopes. It's effective only till the age of up to 55 years. So I think those are the points which are very well highlighted and which also came out of our study. So those things which have to be kept in mind.
Just in the prior talk, this is a question that I was having while listening to this talk. In the prior talk, we saw that the effect of pilocarpine is kind of sustained up to a certain time. And in this particular talk, we have seen that beyond a certain period, when the patients have stopped using the drop, it is not really causing any difficulty in dilatation and things like that. So do we have any idea about, once the drop is stopped by an individual, at what time does the presbyopic effect come back to the original?
So I am not aware of other studies that are there, but ours was a short-term study again. And we did not look at this endpoint in specific. And I think it will be useful to do so. I'm sure we can be, mindful about it, about this aspect as to when when does it wear off completely. But having said this, one more thing came out of the study was that you have to use it twice a day. So, because the effect does wear off after 6 hours.
Right.
Rashmi, can I share one slide and just,
Yes, please.
I had it in my presentation, but then I thought I'll wait for Dr. Rohit. So this is pretty much what I would do. So it's most efficacious in 45 to 50 year old lady or gentleman with the vision of N10 to N12 who is not myopic, So that's -5 is, I think, too much. -2 or below. So most people who are not wearing glasses, right? I mean, these myopes will not be wanting to get rid of glasses anyway, isn't it? So then using it in somebody who is more than -2 and regularly wearing glasses is of no point, because anyway they are wearing glasses. And so it not in myopics, in phakics with and of course who is phakic with clear lens. And healthy peripheral retina, no risk of factors for retinal detachment, and baseline pupil is perhaps more than 3.5 millimeters in mesopic conditions. Right, what we do in slit lamp is it's all bright, right? So just before we increase the illumination, just take a look at the pupil without, you can actually see it, the ambient pupil, and most of them will actually have slightly larger pupils if their age is below 50, and discuss therefore then who is okay to, with the effect lasting for 6 to 8 hours, and if more, then you might have to use one more time, who does not mind reinstilling the drops, right? Because near vision gains are there, and who does not drive at night regularly, and also inform them when started about 2/3 will improve. We'll get N6 if starting from N10, even in dim lighting, but it's in 2/3, right? So not all. And so if somebody says after a whole month of use that, oh, I'm still not happy, it's likely, and so it's likely that they have actually not improved to N6 or even N8. Right? So it can happen in that 1/3 will not improve, and out of the 2/3, 1/3, or even half of them will even go to N5. Right? So this is between 45 and 50, because after that, a lot of other things start happening, and majority will get N6 in brightly lit room for 4 to 6 hours. And of course, risk of complication, though low, we still need to discuss that. There is, so family history of retinal detachment is something that we don't quite commonly ask. But then myopia and other things are already ruled out, because we don't want to give it to patients. So examine, discuss, and inform, and then start. But I still think a lot of emmetropes. What is the incidence of myopia in the population today? Kids, of course, we know that younger people are more myopic today, about 25 to 30%. But then, even if you take that incidence of high myopia in the community, still about 70% are not myopic, right? And, very few are very high hypermetropic anyway. So then at least 70% of the population over the age of 40 would be good candidates for this kind of medication, provided, we go through, this kind of approach.
I think one thing is very
Also,
clear after listening to these two, presentation. This is a drug which should not be, available, off the counter, because we have limited indication, and so much of, people who are not suitable for this particular regime or drug for correcting presbyopia. I think this should be made to understand the people who are using this drop, and we have, as we discussed, pseudophakics should be out of this. There will be people who would have undergone refractive procedure for high myopia, and they are emotrope now. They are also not a candidate for this type of medication. So in fact, it's not for all. That is what we wanted to stress on this. Like, it is not for all, it is for a limited patient who are actually suitable for this medication, for this type of treatment. I think that is a very important point which has come out from these two presentations.
Yeah, I think I completely agree with Dr. Titial, because when atropine came into picture in India, the people started using it left and right without understanding the indications. So this is very much likely, if it comes, then, like there would be a disaster using this if we understand what are the limitations and what are the specific indications. So I am sure it should not happen like what it happened for low-dose atropine.
I would actually,
I think we should
prevent using the word disaster, because it's not really disastrous. And
No,
at least 70% of the population is
at the side effects.
No, I don't. No, that's what that we don't know as yet. But the numbers are minuscule, and having retinal detachment because of even 10 years of pilocarpine is, I think the risk is like really, really small. So it is not for all, of course, and all also won't respond to it. But it is for majority, because majority are still emmetropic above the age of 40. So general ophthalmologists in their clinics would not see, unlike people who are sitting in specialty clinics will see all complex cases. But then people who are in, say, a tier 1 or tier 2 city, who is, predominantly a cataract surgeon, will not see a lot of very high myopes and all of that. So, the utilization of the drug has to be done not over the counter. That is a clear message. It's not for all, but still for those who are emmetropic and looking to, not use glasses on a regular basis, this is relatively good so far as we know. It is efficacious. Now the safety is something that we need to watch, and we all need to get together and have some reporting system maybe where people can actually, like VRSI has something for intravitreal injections and endophthalmitis. Something like that can be maybe established at the AIOS level. But overall, the safety profile, at least at the first month, is not really that bad, provided we actually examine the retinal periphery well. Also,
Okay.
for that washout period, most drugs, glaucoma medications have washout about 2 weeks or so, including latanoprost and timolol. So I would expect something like that for pilocarpine, where it would get washed out in about a week or 10 days or so. That's it from me.
I think one of the most important points that I would like to concise from these particular two talks is that we should, Dr. Vivek, very much I'm with you when you said that, when atropine came. So there should be a group. I would call upon NTOD and AIOS that, we can have certain guidelines in place. We had to do it for atropine. We have to do it for this also. We can have a consensus guideline as to who should be prescribed and whom to prescribe, and that would help general ophthalmologists who really, as Dr. Sen Gupta said, they don't really see high myopes, or it is basically the specialties who deal with the problem cases. But then anybody can walk in anybody's clinic, and it is a good idea to tell them where to use these particular drops. So that we should form a committee or a consensus group at least, where it can be reported, and also it can be, the guidelines can be changed over a year or 2 year or whatever the data comes. There's some questions from YouTube. I think there is one question that what is the effect on near vision, effect on distance vision? I think we already took that. We had a talk on that. Has any other ophthalmologist other than Dr. Kazmi used? Just for myself, well, my wife has used it, Dr. Monica Jethani. She said she has used it, but if anybody from the panel has used it, and they can share their views or their experiences.
I'm sure nobody from the panel has used it.
Okay.
They are
Not
not
willing
in
to use it
They're
also.
waiting for
safety
this
group.
particular meeting to know more about it and then
No,
start
you
using.
don't need meetings to know more about it, but in general, I mean, pilocarpine has been given for so many years for glaucoma. That is a true thing. But then I think if you compare pilocarpine and atropine, they are two different things completely. Probably atropine doesn't give you so many, you can say, quantifiable side effects. Max, it will cause a little bit of blurring, but as compared to pilocarpine, which may give more. And having said this, we don't have enough data, we don't have enough patients, we've not used it enough, and we've not used it across enough geographical regions also, because the brown iris may behave differently from the blue iris as far as the pilocarpine is concerned.
And in the Rohit's talk, he's mentioned about the angle closure, like in the shallow angles, that drug is relatively contraindicated, but this is contraindicated specifically for pupillary block cases, not otherwise.
Yeah. So there's one more question. How many emetropes aged 40 to 50 years in general population are not in need of presbyopic correction? Were they excluded in the study? Dr. Sen Gupta.
Can you just repeat the question?
Yeah. How many emetropes aged 40 to 55 years in general population who are not in need of presbyopic correction, were they excluded in the study? Like they were able to see better and still the drops were put. Were you able to exclude this? Of course, I don't know. You can answer.
No, of course, the question is a little ambiguous. I'm not able to exactly understand the question,
So,
but then here,
yeah, the exclusion
people who had,
yeah, sorry, yes, continue, sir.
no, ma'am. So basically, people who were subjectively complaining were offered. And, if you are willing to participate in the study, you are part of the study, right? So the study setting is all, sort of controlled, right? It's a randomized control trial. So, how many out of 45 to 40 to 55 didn't need it? And those questions can't be answered, I don't think, from a study like that, right? The question is a bit ambiguous and can't be answered well.
Any thoughts on uniocular use in non-dominant eye from Dr. Deepesh Parekh? That is the question which has come on YouTube.
No, so we can actually talk about a lot of things.
Okay.
Like this and that. So I leave it to the user to use it. Unfortunately, I don't think we can answer these kind of questions. Right?
And I think you have to use it to know what the effects are going to be. Like I said, we've not studied it enough. So you can't, and presbyopic population is so diverse and it is so different that for every single subset, you would probably need a different kind of a recommendation.
So we'll move on to the next talk. We will move on to the current surgical management for presbyopia correction. We have eminent speaker, that is Dr. Badman Kankaria, who needs no introduction. Over to you, Dr.
Thank you so much, Dr. Jitendra, and thank you to AIOS for this kind invite. We will be shifting gears here. I hope I'm audible and my slide is visible.
Yes, yes.
All right, great. So basically, of course, we'll be shifting gears here. We have been speaking about this new innovative molecule. And again, congratulations to Entod that an Indian company has thought about some innovative way and also is doing due diligence and also going through the trials in the right manner. Now I'm going to discuss with you what does 2025, what are the options that we have for surgical options for presbyopia reversal. And we all know that presbyopia is what can be called as the holy grail of refractive surgery. So if we just look at refractive surgery in general, you will see that even from the time of Napoleon, which is like 400 years back, people wanted to get rid of glasses. There is a very interesting story that Napoleon actually lost one of the wars because he didn't want to wear glasses and actually could not find the signal which was given from far away. So you can understand that always people have wanted to get rid of their numbers. There have been surgical successes. And if I really talk about today, we have actually had almost a century, about 100 years from the first time a surgical procedure was done as a refractive module. And that was done in Japan in the form of posterior arche. But from that time, about 100 years now, we have truly come a long way. And in this era, we have been extremely successful in treating myopia and to a certain extent also presbyopia of variety of extents. And the success of the current refractive surgery and its acceptance in population goes to this gentleman, Professor Palikaris, who is also my mentor. And he performed the first LASIK in 1990. And this year we celebrate 35 years of LASIK celebration. So what he did was that he actually showcased that with LASIK, it was possible to have a very quick recovery with painless fashion, with a great amount of precision and success with minimal healing response. And that actually got people interested in refractive surgery in general. So those people from 1990s and 2000s who have seen the first success of LASIK are the same people who are called as the baby boomer generation. And they are now all presbyopic, as we know that. And now millennials are joining the presbyopia club. And there is an increase in demand now also for presbyopia correction because they have seen the success with LASIK as well. We have seen already that if there are 50 million people who have undergone LASIK in the last 30 odd years, but we have 2 billion population which is presbyopic. So presbyopia is by far the largest population which is potentially there for refractive correction, and they are actually very, very interested in that. So therefore, refractive surgeons are rapidly adapting to various methods of presbyopia reversal. And of course, there is a continuous research and innovation is getting translated into development of variety of the surgeries. So what is the characteristic of ideal surgery if I want to do a refractive presbyopic correction for my patient? The procedure should be minimally invasive. It should be, of course, very accurate. It should have highest level of safety. We should be able to possibly simulate the postoperative results, show it to the patient. If the patient accepts it, then only go ahead, and possibly a reversible procedure. However, we all know that in presbyopic procedures, there is a compromise that is going to be there somewhere. And that's why we have to always understand the importance of the counseling. You have to make your patient understand the pros and cons of each approaches. So if I look at the current spectrum that is available, you have basically what is called as the corneal approach, which is in the form of either additive procedures such as inlays or subtractive procedures such as laser procedures. Or you also have a modulation procedures such as conductive keratoplasty. You also have scleral procedures which are at your LA, and they're called as the dynamic presbyopia reversal procedures, and use of the new generation phakic lenses which are called as the Viva, or EDOF-phakic lenses. And of course, you have the refractive lens exchange in the form of exchange of your natural lens. So there is a big armamentarium that is available as of today. And as we all see, when there are just too many options for a single disease entity, we know that nothing works the best. So we all know that all these options have their own indications. All the indications will have their own pros and their own cons. And as surgeon, you have to select the best approach for your patients. So basically, as we saw, the first approach that we are discussing about is a very, let's say, interesting approach, which is the scleral-based approach. This is also known as the dynamic presbyopia correction. In this case, the principle is simple. The principle is actually you are creating scleral incisions or scleral spacing devices are implanted to relax the ciliary body. So it is done over the space of ciliary body. Once this sclera gets relaxed, the ciliary body will have more impact, and therefore these patients may be to certain extent able to restore their accommodative response. And this has been basically being researched a lot. There have been now 4 or 5 different procedures which have been researched, but they have been very inconsistent. And because they have been inconsistent, this has not really stood the test of time. There is currently no scleral procedure which is currently commercially accepted by the patient as of today. Now let us come to the corneal procedures. When it comes to the corneal approach, you have basically what can be called as a presbyopic LASIK procedures. In presbyopic LASIK, you may have multifocal ablations on the cornea. So these multifocal ablations on the cornea are basically going to give you 2 different zones, which can be central presbyopic LASIK, in which you have a central zone for near, and then you have a mid-peripheral zone, which is for the distance. Very popular lasers such as Presby Max and the Supra Core, they work on this principle. Then you have peripheral presbyopic LASIK, which has exactly the opposite, in which you have a peripheral near zone and you have a central distance zone. This has not been very well accepted so far, but the most popular technique of today is the laser blending, in which you have a modified monovision approach. It is in the form of the presbyond with from Carl Zeiss and the custom Q approach from the Wavelight. But they all believe and they all rely on the principle of what is called as the monovision. So what is monovision? In monovision, you are simply correcting one eye for distance and you are inducing myopia of in full monovision of about 2.5 diopters, so that you have a full range of vision. Although theoretically this is very good, but practically speaking, this is known to cause a lot of loss of contrast. There is a loss of depth perception, and majority of the population is not able to tolerate it very well. Therefore, from full monovision, we have now gone to what is called as a mini monovision or a micro monovision, in which the difference or anisometropia, which is created either with the laser or you can also do it with the intraocular lenses, is not more than 1.25 to 1.5 diopters, in which you first identify the dominant eye, and this is called as the Miles test, in which either with a cardboard hole or with both of your palms creating a small hole in the center, we actually try to identify which eye is the dominant eye. Then next, you do what is called as a cross blur test in your with your basically Snellen's chart, and you understand to what extent the patient is able to tolerate this cross blur. Once you're satisfied with the ocular dominance and the cross blur, you can actually go ahead and think about doing the laser monovision. So in which patient it works the best? The laser monovision is known to work the best in early presbyopes, which is from the age of 40 years till maybe 50 years of age. So these are the people who do the best because their requirement for reading glasses or reading additions are not more than 1.5 or 2 diopters. So the monovision that you will create will be sufficient for them to feel satisfied at least for few years, and then you may have to enhance them in the future. The studies have also shown that the females have better acceptance of monovision compared to the males. This can also be because of their motivation and also that they maybe have less distance, let's say, requirement, especially in the tier 3 cities or tier 2 cities. They don't drive much. And this has also been shown that especially if you are doing significant anisometropia in monovision, there will be an intraocular blur separation causing loss of stereopsis, which can amount to even more than 50% sometime. And this can lead to binocular depth of focus affection. And therefore, your monovision should only be to the extent that the patient can tolerate. What I do in my setting for patients who want to undergo monovision laser or presbyond lasers, I do a contact lens trial with those patients. So for people who are really, they want to be sure whether they will accept it or not, the best thing you can do is that you can put them with the contact lenses, ask them to use it about 7 days, ask them to continue their life like normal, and then understand what are the issues that they have faced in their real life situations. If the patients come back happy, definitely you can go ahead and plan a monovision or a modified monovision with Presbeyond, and the patients will do extremely well. Now, this monovision approach as such has one big disadvantage is basically this has two different focuses, but there is a blur zone at the intermediate level. And we all know that majority of the work of today, even for presbyopes, has shifted to tablets and the computers. Therefore, this intermediate blur is a true disadvantage. Along with that, this has also been seen that if you actually increase your anisometropia, the patient's tolerance for monovision will go down drastically. And studies have shown that only 60% to 67% patients tolerate monovision successfully. Because of the ocular rivalry and what can be called as the neural subtraction, even though you see the patient is able to see many times 20, 25, 20, 30 vision, but the quality of this vision is actually slightly subnormal because of the neural subtraction and the blur created by the eye, which is actually created for near focus. And of course, the biggest disadvantage is having the loss of stereopsis, especially this can come into play if you're actually dealing with someone who has to do a lot of micro work, especially if you're treating surgeons or even jewelers. So this modified monovision approach has shown a improvement on the disadvantage of monovision. So what is done in modified monovision? It actually combines your micro monovision and it induces what can be called as controlled spherical aberrations. When you do that, you create not a single point focus, but you create what can be called as the extended circle of least diffusion, and that can lead to better range of vision, especially in the intermediate zone, which was lost in a typical monovision. So when you actually have this depth of field, which is improved with spherical aberrations, you can have much better intermediate zone of landing. And with your central neural processing, the vision quality can really improve a lot. So this combination of traditional micro monovision of 1.25 to 1.5 diopters and induction of the rest of the spherical aberrations, you can have a very large amount of field of vision that is available to you as compared to only the typical monovision concept. So this is the biggest advantage of this procedure. One of the biggest proponents of this surgery is Professor Dan Reinstein from London Vision Clinic. And these are the results of a very popular and very established study from his group. And they have shown that more than 96% people actually achieved 20/20 in Jaeger-5 vision in a subset of patients, and 94% 20/25 distance vision at Jaeger-2, which shows excellent outcomes when it comes to combining excellent distance as well as maintaining a very good near visual acuity. Now, when we come to the presbyopic age group, presbyopic age groups also does fairly well, where we have a 92% people who are 20/20 or Jaeger-5 in these cases. So usually the corneal lasers, such as this monovision or modified monovision, is my go-to procedure for patients who have some form of emmetropia. Emmetropia is like they are myopic or they're hyperopic and they are early presbyopes. Now, there was another very interesting concept which came and it made a wave, and now it has now kind of died down. This is the corneal inlays. We have some experience of that. So basically, these corneal inlays are intracorneal lenses. They are implanted in the midstroma of the non-dominant eye of the patient. They improve uncorrected visual acuity by, again, a modified monovision concept. So they were actually brought in for a specific group of patients, and those group of patients were what can be called as early emmetropic presbyopes. That means they don't have any refractive errors for distance, but they just have reading glasses. So these are the different kind of inlays which had come in. The one that we have some experience with is the FlexiView. Then there was basically camera inlay and also the revision inlay. So I'll talk to you about the FlexiView. The FlexiView was a hydrophilic acrylic material inlay, which was only 20 micron in thickness. So this, as you can see, had basically two zones. One was the central zone without any refractive power, and there was a peripheral zone of near addition that you can actually quantify depending on the patient's requirement. And this is the eye tracy that you can see. And eye tracy also does show a ametropic center and a myopic mid-periphery of this, and that actually helps you to achieve what can be called as a smart monovision. The smart monovision means as the pupil goes on becoming in the center, as we said, was far, but as the pupil goes in the mid-peripheral zone, becomes moderately sized, you have the landing of this rays which go to the mid-periphery, and therefore you have much better vision for near. And then again, when you go for far, the pupil is actually going to become much more dilated. And in this case, again, you have much better far vision. So this is a small video that will take you through how it is done. You can see this. This is the femtosecond laser enabled pocket, which is created. We use what is called as the eye pocket mask with the intralace. Once this pocket is opened, you actually go with a specific implantation system. And this is the inlay, which is transparent. And once it is implanted, it is not seen so easily with the naked eye, but of course you can see it very well with the slit lamp. It is usually implanted at about 280 micron, which is almost like mid thickness of the cornea. We had published a series of 31 plano presbyopic patients with this approach with a minimum follow-up of 6 months and a maximum follow-up of 3 years. And we had seen that the near vision went on improving and hit their adaptation at about 3 months, where almost 80% people had almost 20-25 or better near visual acuity on the ETDRS near chart. And we had also seen that majority of them actually maintained a very good binocular postoperative vision. And the compromise for uniocular postoperative distance vision for the monovision eye or this corneal inlay eye was much lesser when you go with the traditional monovision. So these eyes had dropped to only 20/40 instead of 20/50 or worse that we see with the traditional monovision. And they did maintain a very good binocular distance vision. And we had seen that this actually lenses made wave, but unfortunately, some of these lenses were not very, let's say, healthy in terms of their biological health of the corneal stroma. So some of them had to be explanted, especially the wave of the other inlays which had come. This was much better material that we had used, which was the hydrophilic acrylic, but the other materials were not very well tolerated. And as of today, there is, I think, no inlay which is like really used in a big way around the world. Now let us come to the other approach. So basically, we know that the corneal lasers and the corneal procedures work very, very well for the early presbyopic patients. And it can also work for the, let's say, a mid or a late presbyopic as well, as long as your internal crystalline lens is completely clear. Now let us look at this 51-year-old female who had come to us. She had a 6/6 vision with a +1 refractive error for distance, had about +2.25 for reading, had a clear lens on slit lamp. All the investigations were on completely normal. But when you look at what is called as the dysfunctional lens index on the eye tracy, you could actually see that in this case, the cornea was pristine, but the internal aberrations were very high. So in this case, the DLI was very low. It was close to 2. And when you know that when the DLI is less than 5, your internal lens aberrations are too much. So when we asked this lady about the quality of the vision that she has, so she did say that the quality had reduced over time. So this lady, in fact, underwent what can be called as the refractive lens exchange surgery because she was already getting into a very dysfunctional crystalline lens. So when you look at the refractive lens exchange, they're typically for patients who are late presbyopes, who have a very healthy retina, because that is the most important thing that you have to look at. You have to always get their retina completely, let's say, green signal by your retina colleagues. There are a variety of lenses which are available today, which involves the yesteryear's multifocal IOLs, such as bifocal, or the current generation of trifocal diffractive lenses. You also have the current generation of extended depth of focus or EDOF lenses for continuous range of vision. And there has been a lot of research about true accommodative or a pseudo accommodative, which mimics the natural lens movement. So let us talk about the bifocal diffractive IOL. They have been there for very, very long time, for decades together. Patients have been very happy generally with that. They typically have an anterior refractive surface and a posterior apodized diffractive surface, which has concentric rings of decreasing height, and that result in diffraction of the light and gives you much better reading ability. However, this did not have a very good intermediate vision, and therefore trifocal lenses made its way in the last decade. The trifocal lenses are wonderful lenses. We have been very happy with them. This definitely give you much better intermediate vision for very active presbyopic individuals because they use the tablets and the computers a lot. And we have also seen that compared to the yesteryear's bifocal, the current generation trifocals have reduced halos and glare, but they do have significant halos and glare in the night when they drive, and you have to always make sure that you have to counsel them about this. We also know that there are a lot of people now who have very active lifestyle compared to maybe 2 decades back. So this new EDOF lenses, which actually instead of making multiple points of the multiple focuses like multifocal lenses, have one extended elongated focal point, and that is called as the extended depth of focus lenses. They aim to reduce your dependency on glasses for far and for intermediate, and they also reduce it to certain extent for the near. But they have significantly less photic phenomenon, significantly less glare and halos. And if you actually achieve a very, very small amount of micro monovision with them, like one eye plano, the other eye is only 0.5 or 0.75 myopic, these patients, vast majority of the times, don't need any glasses at all. But for the refractive lens exchange, the most important thing that you have to look at always is that how is the dry eye status of this patient. You need a very good profile or treat the dry eye before you do the procedure. Make sure that the retina of this patient is very cool. Always understand how is the corneal specular microscopy. So this is another very, very interesting concept. These are the fluid vision IOLs, which are promoted or they are very, very intriguing concept of restoring almost like a natural accommodation. So they have fluid pockets. And when you actually implant this lens, because of the contraction of the ciliary muscles, it is known to redistribute this fluid in this lens, and it torts the anterior capsule, and thus kind of mimicking your natural lens. Has not shown to have much promise as of now, but the concept itself looks to be very, very promising. And one of the other thing which has made a lot of wave now is these phakic lenses. We know that the phakic lenses, we have been using them for a long time now. They have shown excellent advantage because they retain your cornea for the future. Also, they retain your whatever accommodation is left for these presbyopic patients. But at the same time, they are a potentially reversible and a very safe procedure to undergo. So for the age, which is between 40 to maybe 50 or 55, where you have a very clear crystalline lens, and the patients would want to have a very full array of options available for their cataract surgery in the future, which is not possible with corneal lasers, then these phakic lenses are very promising technologies. Currently, there are 2 lenses which are there. One is the Evo Viva, which works on the EDOF principle from the Star Surgical, and the other one is the multifocal presbyopic phakic lenses from the CARE group, which is called as presbyopic IPCL procedures. We have limited experience of this. We have implanted so far 2 Evo Viva and a very few number of this multifocal IPCL procedures. They are very promising technologies, but again, they are not something which has actually, let us say that, found to be the best solution for each and every patient. So this is a very interesting study which was done by the AIOS group, and they have shown that excellent outcomes from the Evo Viva, in which they have shown the near addition requirement reducing from 1.4 diopters to 0.4 diopters in their series of 80 eyes. And this has actually shown very promising results as well. So with this wide array of options which are available, how we choose that for a patient who is early presbyope, we choose corneal laser procedures in the form of either monovision or the modified monovision approach, such as the Presbyont. For a patient who is more than 55 years of age, especially in Indian context, because we are known to develop cataract early on, we would prefer, in the event of having a very normal retina and the other ocular conditions to be within normal limits, a refractive lens exchange procedure with either trifocal or EDOF, depending on the patient's lifestyle. But for those mid-range patients, if the DLI is very good, then we would still go ahead with corneal lasers. or the presbyopic IPCL or the Evo Viva. But if the DLI on the eye tracing is not so good, then we would still prefer the clear lens extraction procedures for these patients. So to conclude, presbyopia is a holy grail of refractive surgery. There are a lot of different solutions which are available, but currently popular solutions are corneal and the lens-based solutions, which have shown very satisfactory results. The choice of the treatment modality will be chosen only after you understand patients' requirements, their ocular examination findings, and the most important thing in presbyopia, even compared to other refractive procedures, is that the patient should always have realistic expectations. So you have to spend good amount of chair time with them before the procedure rather than after the procedure. So managing patients' expectation is the cornerstone of satisfactory outcomes in the presbyopic surgeries. So again, I would like to thank AIOS and Intode for the kind invite. And just to give you this small bird eye view of the current generation of presbyopia reversal surgeries. Thank you very much.
Thank you. Thank you, Vardhman. That was indeed a wonderful talk. Covered almost everything in terms of surgical management of presbyopia. I don't think we have a question on. There's a question on, can pilocarpine eye drop be used in patients with trifocal IOS or complaining of halos and rings? Is it useful to reduce these aberrations? I think these are new drops, and you can comment more on that. More and more indications will come. You and Dr. Sen Gupta can please comment on this.
So for people who have halos because of aberrations, of course, the pinhole effect, which is created by pilocarpine or also by created by our basically anything that is going to constrict the pupil to a certain extent will reduce their halos and glare in the night. But of course, the role here is to reduce the aberrations because of the trifocal lenses and the let's say halos and glare phenomenon. But I think the most important thing for trifocals, I will always say, is there are two things. Number one is that you have to always counsel them beforehand because they should know if they are going to go through this kind of glare and halo phenomenon. And of course, you have to also give them a positive aspect because vast majority of them, we have seen the halos and glare do reduce with time. So we have seen that in about 6 to 9 months time, in vast majority of them do show a very good response because of the neuroadaptation. And for patients who have been, let's say, relatively unhappy in the beginning, 1 or 2 months, have more than 99% have all settled down by that aspect. But for people who don't, definitely this is one thing that you can look at. But this is not for, of course, your ability of enhancing the reading vision. It is only for the glare phenomenon. Yeah.
I was wondering
Can I
if...
take that also?
Yes, Dr. Sen Gupta, please go ahead.
Yeah, so, any pseudophakic, generally cataract surgery will induce a posterior vitreous detachment, and any cataract surgery increases the risk of retinal detachment, right? That we all know that. So, giving something which also has that additional risk is never good. So that's why, Vardhaman said, not for all. So what I would really look at is if a pseudophakic patient already has a PVD, and so that vitreous traction and all that is not there and doesn't have any retinal degenerations, which are actually very not common at all in the general population. So if a pseudophakic patient who's on trifocal and complaining doesn't already has a PVD, then it makes sense to actually go and give him short-term pilocarpine. But if that PVD is not there, then I would be a little bit more not very keen to start it. So just try and look at that. So only thing is that assessing a PVD is not really easy.
Yeah.
Retina surgeons look at it on a daily basis on table, so we know how to look for it. But generally, for anyone else, it may not be that easy to be sure that there is a PVD. So maybe do a B scan where you can actually see that much easier. So if you're sure that there is a posterior detachment already, this is just to mitigate the risk if at all there is. But then if there is a PVD, then you can be relatively certain that nothing's going to happen. So that is an additional caveat that I would add.
And it's rarely required. I mean, I don't remember any of my patients have put on pilocarpine or such agents after trifocal lenses anyway.
So I was wondering if any other panelists wanted to comment on the surgical procedure of choice that they prefer one over the other in terms of the surgical options which Dr. Vardhaman just elaborated on.
Let's have Dr. Keki's opinion because he would have done most of the surgeries.
Well, frankly, if a patient comes and has difficulty reading and really wants to be without glasses, I think the answer is simple. You just put in a trifocal without much of a difficulty. Now the question always has been raised, what about the rings? Now, I'm a guy who's already had it done. Rings decrease with time. Actually speaking, they actually decrease. In my room, I fitted a little spotlight. On a spotlight, you can see rings. And the rings, first I could see a number of 4 or 5 rings. Over a period of 5 months, the number of rings decreased down to only 2. Now I can hardly see a single ring. And I'm talking frankly, not otherwise. I remember the day I got operated, I went out on the street light to see the famous rings which everybody spoke about. In a spotlight on a big light on a street, it is a halo, it is not really a spotlight. The only problem which occurs is when you're driving at night, cars from far, the headlights are sprayed out. But when they come within a 25-foot distance, it goes away. It becomes almost clear. And over a period of time, it all seems to settle down. But the biggest advantage I can turn on and tell you from my own experiences, I no longer have to fish for my glasses. I can now see intermediate. I can see a newspaper at the top and at the bottom, where previously I had to move my head up and down to see it. So I mean, it makes a world of difference, and over a period of time, it all settles down. I really think that trifocals have sometimes been given more of a bad name more than anything else, because I really am quite happy with them. Maybe I had a good surgeon. But you have to be careful. You cannot, on a trifocal, leave a cylindrical axis behind of more than half a diopter. Patients will not accept it. And the other big problem is that when you take money, which is of a larger amount, the patient expects to get a better result than they would otherwise. That is the other problem. So the two things are there. You have to be absolutely certain of what you do. But on the long term, yes, it seems to give good results. No problems at all. And I've had patients who had monovision. One of the big problems is that they tended to stumble. They couldn't get down a staircase easily. A person with a trifocal runs down a staircase. A person with a monovision holds the balustrade at the side and gropes his way down. I mean, there's a lot to be said one way for the other. Especially on steps which are like marble, you can manage comfortably with otherwise patients have difficulty, judgment is not there. So I think it does matter over the long run. Maybe as the lenses improve, it will get still better and better. We have now started working on the new lens, which is the Rayner lens, which is a spiral lens. I've done hardly about 10 or 12, but apparently the patients don't seem to complain of rings at all. I still remember an old lady, I asked them specifically, do you see rings? And she looked very worried at me and said, am I supposed to see rings? So that really tells you that some of these new lenses which are now coming maybe are an answer to what our old problems were. Maybe I should have waited for my cataract operation.
I think, looking to today's presentation, we have, different sets of people. Let's see a younger generation, less than 50 years of age. There you have these options, like we can go for beautiful, contact lenses or a good, spectacles.
Yes.
But I think the consideration of laser vision correction is also important coming there. Pilocarpine has come as a substitute. And these are people who have a lower degree of refractive towards a hypermetropia. High myopes, as Vardhan was talking about, people are looking to other surgical options like phakic presbyopic implants. Maybe that's another option for future also. And other group is people who cross 50 years. There, I think what Keki is saying, maybe another option there to make them improve their quality of vision by, if they have equipment like eye tracing there, which gives you a one sort of objective point to say, okay, you are fit for a presbyopic lens exchange. So that option may be there. But if I see my own, the experience of Keki and we there, more than 30 years of 35 years of a surgery, pseudophakic surgery being done, and the new nomenclature coming, dead back syndrome. These pseudophakic atmosphere environment is not going to last very long. If we do a clear lens extraction for a person who's 40 years or 45 years, would this bag last for another 40 years or 30 years? Questionable. I think we need to see a different option there. That's why I think preserving the natural lens as far as possible is important. So if I given an option, I will not operate these people till 70 years so that they only have 10 or 15 years, which I'm pretty sure this bag is going to retain in the anatomical what you say, because we have disrupted the entire anatomy and physiology of this, the granule and lens and ciliary body segment. And that is what is the problem. So we should look for those things which is going to give a chance for doing another surgery after some time. I think the clear point is good selection of patients and customizing your approach for these people. And I personally feel what Bardhaman said last word was a good counseling, which is going to be very, very important. Whatever we advise them, the counseling has to be perfect. Otherwise, nobody is going to be satisfied with these refractive corrections. Even a 6'6" people are not happy with us because we are not told them the actual thing. So I think there is the importance of a counseling for these people. And more often, as rightly pointed out, I think Jitendra or somebody, like there has to be a clear guidelines for the general ophthalmologist also, how we should approach the presbyopic people or in fact any refractive error. I think AIOS does have a significant way to look into this. I think people are listening to us. Santosh and Manoj is there. Definitely, we should form one core group to look into this and formalize a guideline for use of not only pilocarpine for other surgical options for presbyopia. I think that will be a good booklet for our people. Yeah.
We have one YouTube question on what about patients with pre-existent POAG? What should be the approach is, I think, what they're trying to ask.
Yeah,
Does anybody want to comment on that?
Yeah, I think the cornerstone of any refractive procedure has always been that you have to have a completely healthy general ocular condition. So basically, if somebody has POAG, definitely, I think doing the other approaches, including your corneal approach or the phakic lens approach, is of course out of question. If the patient has, of course, some amount of cataract which has set in, and so in these cases, basically, you can counsel the patient saying that in the future, when the cataract progresses to certain level, there may be option for you in the future. But I think you have to be very guarded. I think it is best definitely not to do any procedure on them because I think as long as they don't need an intervention such as a real requirement for cataract in the future, you should not do it. And of course, in these patients, out of question to implant high optics lenses because they already have a less contrast because of their glaucoma and stuff like that. So definitely not a great choice of patients. I think you should always counsel and deter them using all these approaches, in my opinion. Yeah.
I think the question relates to Dr. Sabyasachi, because if patient has a POAG, pilocarpine may be a treatment for those people. Would these people benefit with pilocarpine both ways, like decreasing the intraocular pressure and also improving their presbyopic condition?
So actually, the study measured the IOP levels, and I showed a graph where there is almost no change in intraocular pressure with a 1.25% pilocarpine. So I don't think it's going to add too much to their IOP drop. Again, also, somebody who is a POAG and requiring like 2 or 3 medications would have crossed 50 most of the times. They are a little older, so they are almost, like a different cohort altogether. So, if you have somebody who has an advanced POAG and still wanting to get rid of glasses and, all of that, despite so many drops and so much of visual field effects, I think there is almost no overlap. So coming across a scenario where a POAG patient on 2 or 3 medications will want to get rid of glasses with pilocarpine would almost never arise. So then, most likely there's not much overlap there. If at all, avoid it.
Yeah.
Probably an early glaucoma who is on 1 bottle of medication, probably pilocarpine in this case, not 1.25, but probably 2% can be tried as a study. That can reduce the IOP plus give some sort of a presbyopic effect to the patient.
I
But
wonder if using pilocarpine for this indication in glaucoma patients, would it affect the monitoring of the patients in terms of the fields and because we need to do
Certainly reduces
HVFs?
the, yeah, certainly
Yeah,
reduces the sensitivity values in
yeah,
visual fields. Up to 3 diopters reduction is seen in meiosis cases.
right. Dr. Titial, you were trying to say something, I think.
no, as Sabir rightly said, it is 1.25 may not make any difference in the IOP, this thing. That's why people are use 2% pilocarpine, these things. But these are patients, as rightly pointed out, they are already crossed, 45, 50, 55, and their dynamics of, accommodation would have changed by this time with the, all those glaucoma medications. And using 2% pilocarpine is not a good idea in today's scenario, because the subsequent cataract surgery becomes so tough in these people, and you disrupt the entire pupillary dynamics. And trifocal will never work in those cases, because the pupil would have you have to stretch the pupil in all these cases. But whatever said and done, as basic idea is to have knowledge which are those patients who are going to benefit with a different option of treatment. I think people understand this, we would have a, we'll not, defame the, one particular good option for these people, because we don't actually select the patient appropriately. That's why we have so much of, questionable things coming up. Even for a simply for a, your spectacles, just for a bifocal to progressive, if you don't counsel them properly, don't give a proper option, these are very unsatisfied patients, because they spend money for a progressive lenses. The same thing happens to surgery also.
Yeah, I think in the continuation with what Dr. Titial said, it's like I would correlate with the tale of Aladdin. The new lights are being offered to the old, and that's how we are offering new sight for old.
Right. I think I would just request Dr. Titial now to just summarize the session um, on the current understanding of the indications of pilocarpine for presbyopia and what are the future approaches.
Especially, I've
Dr.
already summarized the things. What I would say,
Yes, more or less.
some things are very, very important for not only for a people who are actually practicing. Like we have done so many research in our various areas. The research should be such which ultimately benefits the clinically to a group of people. And this particular area, refractive surgery, is one which benefits the people of all the age groups, right from the, right now we're talking about myopia, like, control of myopia to a pilocarpine. So we have atropine to pilocarpine, similarly the refractive surgery part also. But looking into a future-wise, we have a large population of presbyopic going to be with us. Not only the the physiological presbyopes, which are going to be around, emotropes will require around 40 years or so. If you are a little myopic, maybe 45 years. If you are hypermetros, maybe 37, 38 years. If you undergone refractive procedure, again 37, 38 years. So we are in fact adding younger people to get presbyopic earlier. We're talking of millions of people undergoing refractive procedure. These people are going to presbyopic by 37, 38. There, I think the option has to be very, very clear. But I have seen in my experience, most of these patients who undergone refractive surgery, they get into a little myopia by the age of 38, 39, and they benefit for another 4 or 5 years. But the major challenge is, the age group 45 to 55, which is the actual, very active, professional age for most of us. And there we have to give these options, because you cross 55, you are already, thinking of different things. You're reaching 40 to 55, this 15 year, 10 to 15 years, a very, very active age for our Indian population. So that is an area we have to think of. And this pilocarpine may work for benefiting this group of people. The working people, put one drop in the morning, you're okay for the entire evening. If you have evening functions, maybe put evening conferences, something like that, meetings, you put one drop at that time. Only thing I'll request Sabyasachi and the Rohit group to do a study for long term. Look for these people for 3 years, 4 years, 5 years, what happens with these people, what are the changes. And that will benefit all of us in terms of knowing the actual role of pilocarpine in these early presbyopes are low refractive error people and the side effects as such. Surgical correction, which Vardhaman talked about, we all know that we have been doing, and some of them are historical also. Some of them have done well. And I personally don't like to fiddle with cornea as far as possible, because cornea should be totally clean. It should be pristine to have a good optics for future also, because you're going to go undergo cataract surgery in future after 10-20 years. If cornea is clean, you'll have a better outcome in those cases also. Yes, if no other option, why not? Looking into an experience of faking IOS, I had an experience of almost 7-8 years with care group lenses. They are multifocal presbyopic IPCL. The only thing I have seen there, patients are very happy because these are high myopic patients. I've taken higher myopia, like more than 3 diopter myopia, and a little bit hyperopic patients. So these patients are very happy. But one thing, my follow-up now ranges almost 5 to 7 years. There is a rapid initiation or increase in the nuclear cataract in these patients. And around 10% of these cases, in 3 years, you'll be doing cataract surgery in the age group 40 to 45 or 50 years. So that is a challenge for putting anything in the this posterior chamber area. Otherwise, the results are quite okay. I have not used the Evo Vision lenses. They have recently come, but their range is also very, very less. Ultimately, it boils down to some sort of presbyopic surgeries. If you have a good accommodative lens, why not to have that option also? But as far as if summarize one word, we have a population where you can target them, precisely for giving different options. But careful selection of cases and long-term benefits should be looked into these patients. And what we have to do as a AIOS people is to have one consensus meeting for a presbyopia and look for a various option, and we'll do very, very soon. Thank you very much.
Wonderful. So thank you so much. And we would now like to ask Dr. Manoj sir to have closing remarks.
Yeah, so on behalf of the All India Ophthalmological Society, it is my privilege to propose a vote of thanks for this enlightening webinar. My thanks to Dr. Partha Biswas for being the chairperson for the event, Dr. J.S. Titiyal and Dr. K.K. Mehta sir for their presence as co-chairmen and their valuable inputs for the session. Of course, the moderators, Dr. Rashmi Deshmukh and Dr. Jitendra Jethani for moderating this session excellently. The panelists, Dr. Namrata Sharma, Dr. Vivek Varkad, and Dr. Inder Mohan Rustagi for their inputs. And last but not the least, my congenial thanks to all the 4 speakers, Dr. Aditya Sethi, Dr. Sabyasachi Sen Gupta, Dr. Vardhaman Kankaria, and
Rohit Saxena.
And Dr. Rohit Saxena for their wonderful expositions about this topic. So, and last but not the least, to all the delegates who have attended this enlightening webinar, and my congenial thanks also to Endrod Pharmaceutical for their support for this event. Thank you all. Let's close the meeting now.
Thank you.
Have a nice day.
Thank you.
Thank you. Thank you, everyone.